welcome. I'm Dr. Hunter Greene. We are here with Healthcare Unscripted. I have as my guest Dr. Dustin Richter. We are good friends. We have spent many hours in the lab together teaching residents and fellows the fine art of arthroscopy and also how to begin life as a new doctor coming into practice. Today's episode is going to focus on subspecialization, whether you want to do it, and if you do, what's the best choice for you moving forward. Dr. Richter, thank you so much for joining us. Dr. Richter has spent most of his training and education at University of New Mexico, and then he did his sports fellowship in University of Virginia. He specializes in sports medicine, like myself. We have kind of mirrored practice in the sense of we do shoulders, hips, and knees. And then difference is I'm in private practice and he's in an academic practice. I think I started in 2005. I'm actually not sure when you started practice.
I finished fellowship in 2016, so been at it for right at 10 years now. But Hunter, thanks a lot for having me on. This is great.
Yeah, this is, as it says, it is unscripted. We will kind of move through a little bit of some topics, but really it's just more conversational to kind of help educate, just like you do and we do, these people as you move into your orthopedic career, your choice in subspecialization, whether to stay a generalist and then whether to move into a specialty. And then, nowadays things have evolved. When I was finishing residency in 2005, there were still a lot of people that would just leave residency and go into practice and kind of find their way. And, now I think it's kind of a heavy trend towards fellowship training. And I don't know if that has to do with the resident work hours and not enough volume seeing cases during your residency time and need to see some more, or just an interest in subspecialization. Tell me a little about, I kind of fell into my kind of niche in hip arthroscopy as I came through training. I went into fellowship. When I was starting fellowship, the person I was going to work with, Dr. Mark Safran, was sort of an elbow specialist at the time. But when I got there, he's like, "Hey, I'm starting to do some hip arthroscopy. Do you want to learn how to do it?" And I'm like, "Sure." So I kind of
had no idea Mark used to be an elbow specialist.
Oh yeah, my research that I did with him was on UCL. We were doing a X-ray, sort of almost like a Lockman testing device for the elbow that you kind of stress load it on unstressed and stressed X-ray views, and that was the paper that we worked on and put together. And that was just because he had that in the docket there as we were moving through. But when I did my interview, everything else, that's what we talked about. We did some elbow work. But when I got there, he's like, "Hey, I'm doing this new thing, hip arthroscopy," and we're like, "Sure, okay, let's do it."
Right.
So we learned together, and he's obviously an expert in the field and world-renowned guy in hip arthroscopy. So that was kind of fun to learn that with him, and then just learning with my other mentors in fellowship, Dill Cannon, who was like the master of the ACL and knee arthroscopy. And at the time when I was working with him, we were shooting video clips for back then, which was unheard of, sort of a augmented reality or VR sort of knee arthroscopy trainer. That is kind of
that's cutting edge then for sure.
Yeah. But Dill is that. I mean, he was a guy who used dragon speech, way back then. So he was doing all these things for a guy who was at the end of his career. He was very technologically savvy and was kind of the forefront on teaching residents through this kind of augmented reality. So we did a lot of video clips during knee arthroscopies, and he's like, "Okay, now pull back out of the knee and go into the notch." And so he was getting specific clips for what he wanted, but a wonderful teacher. And then I was working with Dr. Ben Ma, and he had just finished at HSS. He was kind of the shoulder guy, and we did a lot of shoulders together and learned a lot. It's a strange thing, shoulder arthroscopy. As I was finishing residency, we were still doing a lot of mini open cuffs. And we had a guy who had come back from HSS, Chris Wall, who was one of our chief residents when I was there. He came back and he was doing arthroscopic cuffs, and nobody really in the community was doing that. And you think arthroscopic ACLs were like early 90s, but this was early 2000s, and you're just starting to do arthroscopic cuffs.
Right.
So kind of a crazy thing. When I came out to Sacramento, pretty much everybody was doing mini open cuffs, and their ACLs were spending the night in the hospital. And so it was kind of
then 10 or 15 years later, after you're doing the arthroscopic cuffs, then it's arthroscopic hips more and more. You and I both, like you said, doing the shoulder, knee, and hip. And what I love is that you can use techniques that you learn in the shoulder if you're doing an SCR or an augment, and you can utilize that in the hip and vice versa. And I think it's been nice to be able to kind of cross-train with some of those instruments. You find uses that aren't necessarily run-of-the-mill.
Oh, for sure. Because I mean, back when we started doing hips, all we had was shoulder instruments. There weren't hip instruments.
Right.
So that was a lot of adaptation at that point. But I really think the suture management you learn in shoulders is invaluable for hip arthroscopy.
Yeah. Couldn't agree more.
Working such a distance. How did you kind of end up in the sports world?
Yeah, mine's kind of unique. I had spent time with Bob Skank, who the Skank knee dislocation classification system's named after. He's whole reason I actually went into medicine at all. So used to be an engineer, oil and gas business, and when I was finishing up my college, I spent a summer shadowing Bob Skank, and I just I had an idea that maybe I want to do medicine someday, and had probably similar to you, a lot of the interest with science and math that drove me towards engineering some. But I was like, I may want to do this someday. And a hospital administrator was like, this guy owes me a favor. And she put me in touch with Dr. Skank. And I spent the entire summer with him. And after I finished that, I was like, you know what? I'm pretty sure I want to go into medicine. And if I do, I want to be an orthopedic sports medicine surgeon. He just loved what he did, and working with athletes of all ages. You see your high school and college athletes, but then your patients in their 60s and 70s and rotator cuff tears and other issues. And it really adds a huge breadth, because it feels kind of similar to a general practice, but with just a lot of arthroscopy, but you're getting to do a lot of different things. So I never get bored with it.
Yeah, that's the kind of neat part of sports is you do span the age spectrum from the adolescent sports all the way through now with our very active population in pickleball.
Yeah, right.
Yeah, we see and it's amazing. You see these, late 60s, early 70s people that come in your office that are fit and active, and they do a lot.
So chronological age, you just can't look at anymore.
Yeah. So do you think, as far as the residents that you work with and kind of coming through, do you think a lot of their subspecialization is based on kind of a mentor that they found and that they like?
I think part of it is based on that. I've talked with a lot of residents and fellows about this before, because we used to pride ourselves on, here, they finish residency and go hang a shingle. You can go into general practice. You'll be a great orthopedic surgeon. You don't need the additional training to learn how to operate. We feel comfortable, especially at New Mexico. It's like our residents come out and they're ready to rock and roll. But I think that the reason more and more people, greater than 95% are doing the subspecialty training is I think it makes you marketable. So whether you're going to a smaller community, if you want to do academics, no matter what that is, I think that it's something that people are kind of hanging their hat on, that they say, look, I have this ultra subspecialty certification, and they're using it with social media, and hospitals are saying, here, we have a board certified orthopedic surgeon who is subspecialty trained in knee and hip arthroplasty, or, whatever that may be. And then I think if you look one step further with the legal world and medical legal stuff, they're looking at people who have more subspecialty training. Well, what are the credentials? And whether that's right or wrong, that's kind of the way things are going.
Now, does the generalist exist in the academic community?
Yeah, that's a great question. Boy, I think they're hard to find. It's a dying breed in the academic community.
Now, is there community academic faculty that are generalists that the residents get exposure to?
Not here, not in Albuquerque, but they do spend some time certainly with community folks that may be sports trained, but do a lot of joint replacement, which is not uncommon. And like you said, taking care of patients, it's almost like cradle to grave. You see them when they're younger and they may need an ACL, and then maybe they need something with their meniscus later on, and eventually maybe a knee replacement. And being able to kind of treat that patient throughout the course of their injury and problems is pretty satisfying. And I think you build those strong relationships.
In our training, the faculty was, present, but in New Haven, there were 3 kind of major orthopedic private practice groups that we worked very closely with. And they had guys who had trained at Yale and then gone on to fellowship training, but other guys who had just trained and left and ended up in the community. So we saw, hand fellowship trained, spine fellowship trained, sports, but then also a good kind of mixture of some just general guys that, like they said, they would do a knee scope followed by, a total knee, or they would do some trauma work, they do some, fracture care, and then do a carpal tunnel. So they were that true generalist in the sense that, yeah, they felt comfortable doing those things. They probably wouldn't do a multi-ligamentous knee, but they felt comfortable doing general orthopedics.
And I think you and I have that passion for some of the teaching that we've done and some of the lab work with, the early career surgeons. So chief residents, fellows, people in their first or second year. And you see that. I mean, most people go into private practice, but you have to have a fairly general practice most of the time when you're starting off. Just taking care of whatever comes in, doing trauma, doing carpal tunnel, doing whatever. And that kind of builds your foundation to then hopefully get that niche that you're looking for.
That leads right into the next thing I was going to ask you about, is that when I talk to younger people, and I think you do as well, it's helping them understand that first 3 to 5 years of your practice. And yes, you are a subspecialist, but unless you end up maybe in like a academic setting where, yeah, they need a shoulder guy and you're going to take all the shoulder volume, most places you end up, you're going to have to do some general work or some things outside your subspecialty to build your reputation, to get yourself out there, and also just to fill the schedule.
Right. Yeah. You'll probably do more hip fractures your first year than you do ACLs if you're a sports surgeon. It's just building that up. And the 3 to 5 years is real. I mean, I truly think that at the 5-year mark is where I was seeing what I wanted in clinic and the OR, had built that schedule and that referral base that just continues to mature.
Now, did you know it was going to be that 5 years, or did it just, you felt it when it happened?
I had been told it would probably be 3 to 5 years. And then I think looking back, it's not like, no, it's not great. And then, yes, it is. Kind of melds into each other.
Yeah. Once again, it's hard to believe that you've gotten 5 years into your practice. That part was like, whoa, you kind of look at your schedule like, oh, I'm kind of doing the things I want to do. And, right. You see that there's more of the sports stuff and less of the extraneous stuff around it that you had to do early on to get to where you are.
Yeah. And, we've chatted some before that, if you get to that 3-year mark and you're not seeing what you want, you're still pretty far off, that you do have control over some of those things. You've built your name a little bit in the community, but you can certainly build your brand and establish who you are and reach out to your referral base with physical therapists and primary care docs. But at the same time, you have control over your schedule. And hip arthroscopy, we go through a lot of patients with a bunch of different problems to get down to the ones that truly would benefit from hip arthroscopy. And I think, putting some parameters on there about what kind of patients you're going to see and try and sort a few things out to whittle it down some can be helpful.
Yeah, we talked about that recently. And that, like you had mentioned, referrals, in an academic setting, they may come from your partners within, a hip surgeon, a hip arthroplasty surgeon sees somebody that's, 40 that, hey, this guy's joint doesn't look that bad, but it looks like he's got a cam lesion. Right. Let's come over to Dr. Richter and see what's going on. But also just from the community in general. Now, early on, did you go out and give talks to the primary care docs, to the family practice, to physical therapists to try to start to educate them on what you're capable of doing and what you want to do?
Yeah, I actually did, even though I'm in an academic setting and came into sports heavy practice. I still wanted folks to know what I did. And similarly, how do I like my rehab with my patients and protocols? Because there wasn't a whole lot of hip arthroscopy being done in Albuquerque before then. So, I went to 6 or 8 different physical therapy places, bought them lunch, and did just like a little lunch and learn, 45 minutes and present on myself and maybe talk about hip arthroscopy, what it is, why we do it, what rehab looks like afterwards. And then similarly, another passion of mine is the knee dislocations, multi-ligament knee work. And that's even more rare than hip arthroscopy. And that's somewhere where reaching out to like my other orthopedic colleagues who may be community practitioners and stuff like that and tell them, guys, you do not have to treat this if you have zero interest. And if you see the show up in clinic and, it's like a bomb went off in clinic, it's like, just text me, call me, send me those patients. That's something that I enjoy treating and I can take off your plate. And I think the overwhelming response was people were really happy to hear that.
Oh, for sure. And then that just builds that reputation, that builds that communication. One thing you'd said is, just having that availability, say, when you go meet with the physical therapist, you go meet with the primary care, here's my number. If you need anybody to get in, just send me a text, give me a call. We'll get them into the clinic. We'll get them seen, and like, we're happy to take care of these things. That sort of, the old thing, being available is everything. And your willingness to see and take care of those patients, and then get the follow-up when they're through the process and they liked what you did, then that kind of slowly just builds that reputation for you, and keeps the referrals coming in that direction. But I think you're so overburdened early on in your practice with figuring out documentation, figuring out billing, and then like you said, that kind of that black hole is scheduling. Like, what happens? How does it happen? How do the referrals come in? How does that process go? And like, a private practice versus an academic center, there may be a just general referral center that everything gets funneled in your setting, and it just kind of gets, it kind of gets ticked out into who and where and, whatever. And yeah, a little coffee and donuts to the scheduling department every now and then, just to like, hey, this is what I like.
Exactly. Yeah. Yeah. I mean, that's a great point. Like looking at that schedule and seeing, for us, it's how many established patient slots are there? How many new patient? How many acute care slots? What signifies an acute care visit? And, I don't want my 15-year-old soccer player who had a knee injury wait 8 weeks to get in to see me because that's the next open slot. Right. It's, telling people and communicating that, hey, these are patients that we want to see as soon as possible, for sure within the week, maybe within 2 to 3 days. And, it's about that availability that goes a long way, but you have to talk with the schedulers. You have to look at what does your scheduling parameters say?
Yeah. And I think just for me, surgery schedule and office schedule, no offense to the arthroplasty people, but I mean, if you have arthritis, you're going to have arthritis in 3 months, and it's not that big a deal. But if you have an ACL and you have a season, or you're trying to get back to something, that timing is relevant. And, same thing with an acute rotator cuff tear. You have a 48-year-old firefighter who's got a traumatic rotator cuff tear. Yeah, 6 weeks out, that guy's toast.
Yeah, that's what I just did 3 hours ago.
Yeah, so the timing on those, if you're within 2 months, that's an easy case. If you're beyond 6 months, that's a horrible day. Right. So I like to be within 4 to 6 weeks, for general cases to kind of get on. But then if you have something like that, my scribes let the schedulers know this has to be within the next 2 weeks. They got to find a spot for them. And just my general schedule, I like to have people be able to get in to see me, within a certain amount of time.
Yeah, we want to dictate the timing for treatment. We don't want it dictated to us when they show up super late and then you're kind of hosed with what you can actually do for them.
And that's where one thing as you get into practice, referrals are things that will stymie that process, waiting from, getting the referral from the pediatrician, for this kid with an ACL or a bucket handle meniscus or something like that like, oh, we're waiting on the referral, like, let's go. But then you have to kind of implore the parents or the patient to advocate for themselves and like, hey, go sit in their office, just get it, bring it over to us. We'll do it. So exactly. You have to get that sort of level of communication with your scheduling department so they know. But I think that's the one thing I think early on in practice you don't pay attention to. You focus on, documentation, billing. Scheduling is just that black box or that black hole you don't understand. But I think if you make that more relevant to you, understanding the referral process, knowing where the referrals come from, how that process goes, what do they need, and and which insurance is needed. Unfortunately, a lot of insurance companies, require referrals nowadays.
And letting the people that are referring, your colleagues and everyone know that, hey, I want to see these patients. I'm going to go out of my way to help accommodate them. And like an example is I had one of our peds folks have a patient come in from about 4 hours away, saw him that morning. And he's like, they have FAI, they have a labral tear, a huge cam lesion. They're like, you need to see Dr. Richter. And, they came from 4 hours and they're just across the street right now. And so he picked up the phone, gave me a call. He's like, look, I know you have a busy clinic. Is there any way you can squeeze them in? And it's like, absolutely. Trying to accommodate folks like that goes a long way. People remember that.
Oh, for sure. I mean, yeah, that kind of availability is priceless in the sense of now wherever that guy goes back to that community, you're going to be known, and that, hey, guy did me a solid, helped me out, took care of me when I needed it. You do that once or twice, and man, you're locked in.
Right. Exactly.
Now, just kind of moving a little bit into community versus academic practice. Now, you said I think you see a lot of people going into kind of the community side. Now, there's the difference between the community side and the employed versus the private practice versus, the large organization like a Kaiser or like academic. What do you kind of get the sense, just talking to the residents and fellows, where they're ending up and why?
I think more of them are winding up in kind of large private group or employed by hospital. The smaller private groups, I know that you're part of one, but a lot of those just haven't been as sustainable, and it seems like they're getting eaten up by some of the bigger groups in a lot of areas. And I think that when we talk with a lot of our residents and fellows, they kind of like the idea of having more of a guarantee, even if there is a lower ceiling with it, so that they have some sort of guaranteed stability when they're coming out of practice.
Budget planning, yes.
Budget planning.
Yeah. So I think that's interesting because California is sort of a weird market. There's not a whole lot of these large groups like you see in a lot of the other outside of California. I mean, there are some massive, like 150, 170 surgeon groups that are just like, holy cow. I mean, that's like Northern California Kaiser. I mean, that's like,
that's more than like all of New Mexico orthopedic surgeons.
Right. Yeah. So, but they're massive, these groups, and they have hospitals, they have physical therapy, they have imaging, they have rehab, they have everything under one roof. And yeah, I mean, you're basically a health system at that point. I mean, the way they run these. And I guess, from that side, it's a very attractive for someone young coming in, because once again, the predictability is there. Whether you have kind of the customization of some of the things that we were talking about, you may not have that customization on your schedule until you get to a little higher, more senior position in that practice. You may be doing your general stuff a little more on, but
that's true.
But those are questions, I think, as you go through the interview process, kind of asking and being insightful about some of those things that may be happening to you. Now, in the academic world, as far as specialists, how subspecialized are they looking for?
Yeah, I think it depends on where you want to be and what you want to do. You can get ultra subspecialized, and they talk about, the people that do 2 or 3 fellowships and sports medicine fellowship and a pediatric fellowship, so you can do pediatric sports medicine. And what I tell people is think about what you want to be doing down the road. If you want to do pediatric sports medicine, you should be able to get everything you need from a regular adult sports medicine fellowship, because you're going to be treating adolescents. You're going to learn techniques. You can learn how to do an IT band reconstruction for an ACL in your 8 or 9-year-old. There's not really anything substantial, but if you do a pediatric fellowship, then, you're doing club feet, hip dysplasia, that sort of stuff. So, be thoughtful about what you want to do. If you plan on being in academics and you want to publish a ton of papers every year, then, that might be the ultra subspecialized. But the way I think of fellowship is that you should, again, come out of residency knowing how to operate. This is really just kind of refining those skills that if I wanted to do all general, I could, but I wanted to learn about arthroscopy in more depth and detail and patient selection and kind of the finer details of that subspecialty.
Healthcare Unscripted is powered by Fairwinds Medical, the commercialization team behind some of the most innovative technologies entering operating rooms today. With national reach and clinical expertise, Fairwinds moves new solutions from promising to practice. Visit fairwindsmedical.com to learn more.
Yeah, I think for me, the kind of thought of fellowship was just, you see it all in residency. You can do it all. Like I said, you have
Right.
to know how to operate. And this is just a more focused area and additional bit of training with someone looking over your shoulder and getting better at these things. It really is an apprenticeship in that one specific area. And so I think that's really important. But I think, it's, that you said about the peds sports side of thing. When I was coming out of training, I was looking at peds, trauma, and sports. So I kind of thought to myself, I'm like, well, trauma-wise, pretty much anybody let me do it at a trauma one because nobody wants to do it anyway. I don't need to do a pelvis or anything like that. But other than that, I feel pretty comfortable rotting most things and fixing most things. So, and then on the ped side of it, exactly what you said. Adolescent sports medicine that's part of sports medicine. I mean, it really is. I mean, you're going to see, a 14-year-old girl with an ACL that's probably skeletally mature or close enough that you're okay with it. But I mean, and then I can tell you in 20 years of practice, I mean, the number of 8 or 9-year-olds with an ACL that was something you want to do, it's like, I mean, that's less than a handful.
Yes,
so that is such a rare thing. And, you're going to have somebody in an academic institution nearby or Shriners. We've got a Shriners down the street that, okay, that one kid's going to go there and the parents are going to appreciate that you sent him to that place. You're not losing business because of that. They're thankful that you listen, I'm not going to practice on your kid. I'm going to, send you to the place that they do a lot of these, or nobody really does a lot of these, but at least they have people that have done these.
Right. Yeah. I mean, with the ultra subspecialized, I don't think I would get as much joy out of everything I do. I love the mix, as I know you do. It's kind of like, when I have a shoulder on, a hip on, and a knee on, it's fun. It's like a tour around the joints of the day and get to do a little bit of everything. Now, one area that does impact both of us are the folks that do like a hip preservation fellowship where they do arthroscopy, open periacetabular osteotomy, that sort of stuff, which I do appreciate because I don't do any PAOs as part of my practice. And I love having that person or people that you can refer to that I know are very well trained for that specific thing. But, that's pretty few and far between.
Right. I think if you're in that sort of hip preservation specialty world, I mean, you're only seeing hips. People always ask me, like, what's your favorite surgery? And I said, well, I have 3 boys and I have 3 joints that I work on. And I love them all for different reasons.
There you go.
So that's
a great line. Yeah.
It's very easy. And it's true because there's certain nuances of an ACL that are just great. Cuffs are like always different. There's never, really 2 that look alike. They all come in different varieties. And then I think I just love the technical aspect of the hip arthroscopy. From your engineering background, I mean, you must love sort of that 3-dimensional thought process of the camera section that is there, just the traction, the vectors, that sort of side of it is very different. With the cuff, it's like the arms are in the same position the whole time you're doing the cuff mostly. Right. Whereas the hip it's dynamic. I mean, you're moving that joint around, you're changing from one position to the other, you're using a 70-degree scope, you're looking at things differently. So I think that side of it is really intriguing in the sense that each one gives you a little different flavor of your arthroscopic skills.
Yeah, couldn't agree more.
Yeah.
Some days you're humbled.
Oh, for sure. Yeah. And it's you're so routine in the way you do it, but every now and then you kind of get like, you have to take a step back, take a little breath, and like we talked about with our fellows, irrigate a little bit so you can think. So
exactly.
Yeah.
Exactly.
So that's fantastic. Now, how do you help? Because you're a little more in line with it than I am, with the residents. When they come to you and they're like, I'm thinking about spine, hand, and oncology, what kind of guidance do you give them as far as trying to help them hopefully get close to where they want to be?
So I think first off, of course, it's kind of keeping your mind open. But one of the big things is that when you're rotating through, see if you like the patients that you're getting to meet and the surgeries that you're doing, not necessarily the people that you're working with at that facility. Because you may go through a spine rotation and it's like, oh, there were 3 fantastic spine surgeons and you got along so good with them. And well, you're doing spine because of that. And I see that too often where there's certain divisions that it's like, oh, I love these surgeons that I'm working with, so I want to go into that. But you have to make sure that you love what you're treating with the pathology and the follow-up with these patients so that you don't go into it for the wrong reasons.
Oh, that's so valuable, because that setting that you're experiencing is not the setting you're going to be in when you're out practicing, unless you end up joining that practice, which is rare.
It's rare. Does happen, but it's rare.
Yeah. The way you said it was the patients you'll be treating, because that's really where it's at. I remember in my rotation, our spine guys were awesome. They were so fun. They were excellent to work with. But like, I had carpal tunnel surgery when I was in residency, and I had to do 2 weeks of spine surgery. I couldn't operate for 2 weeks. That 2 weeks of spine surgery told me I never wanted to do spine surgery.
Right.
Because dealing with those patients only all the time for 2 weeks straight, it was like, yep, nope, not going to do that.
Yeah. I had a similar experience with peds ortho. I had surgery myself, a thumb ulnar collateral ligament repair, and I was in a splint for a few weeks and just did clinic. And I was like, this is not something I really want to do anymore.
Yeah, so that's funny. Similar sort of experience. But yeah, but I think that the value of what you just said is the patient population and the surgeries that you're going to be potentially doing, not necessarily the people you're working with.
Yeah, see what gets you excited, right? Like, what do you go into and you want to like read more about and dive into and understand everything you can about it because you're passionate about it. You know, it's like a good book or a hobby or something like that. Then that's it tells you, you know, and you'll know hopefully after your third year, by the time you're ready to apply for fellowships.
Now, do you talk to them about sort of that 5-10 year sort of view of their practice? Because as you know, in orthopedics, what I did when I first came out, as far as like once again hip arthroscopy, what was available at the time, we were doing labeled debridements. We didn't repair anything. We did really bad camera sections and things like that. But then things have evolved. Now we have the hip checks, the hip maps, the fancy, you know, stuff that you can do. We have anchors galore, instruments galore that we didn't have. And you just think of rotator cuffs, like we didn't have any sort of biologic augmentation that we're doing. You know, we had some decent anchors, but not great. Suture passing was challenging. So when you think of that specialty, you look at arthroplasty now, the world is dominated by robotics. Right. And you know, augmented reality or virtual reality that's coming into it. Spine the same way. There's a huge push in spine for augmented or virtual reality side of things. All this interactive CT-based stuff that's going on in the OR, with live, you know, screw targeting.
Everything so rapidly, yeah.
So that stuff, I think you have to think about that too. Is like, okay, yeah, you may love the surgery now, but will you love it in 10 years when it's this? Right. Or are you going into it because you think in 10 years it'll be this?
Yeah, yeah. And we don't know what that's going to look like. You know, I use this kind of analogy so when I was, again, working in the oil and gas business for Exxon, that was back in 2004, 2005. And they were like, well, oil and gas reservoirs are going to be dried up. You know, no one's going to be using oil and gas in 10 years. But, you know, the stuff that people have forgot about are the technological advances like you're talking about. You know, they weren't doing horizontal drilling and deep sea drilling and fracking and all this stuff that just, I mean, exponentially expanded the reservoirs they have. So when we think about what is medicine going to look like, we don't know, but we know there are going to be those big items that change it. And I've listened to the talk that you've given on artificial intelligence in medicine and stuff like that. And I mean, this is going to be real, and there's going to be some stuff that's going to be beneficial and some that won't, but we have to be thoughtful about what's coming down the road.
You think they can future-proof their specialty?
I think there are specialties in medicine that AI will be more beneficial and will take over and be efficient and stuff like that. And it's already happening. I think that as surgeons, we're a little bit more insulated, but I think we'd be foolish to say that we're completely insulated from robotics, from AI, from stuff like that. Now, you know, when we do an ACL, no two ACLs are exactly alike. There'll be a notch that's a little bit tighter. There's, you know, a back wall that kind of extends out a little further. There's the management of soft tissues. And I think that's going to be a little bit more hard and nuanced. But we have to be thoughtful about that down the road. I don't think there's anything that's completely insulated from it.
And I think the beauty of it is like you were kind of saying, is we fortunately still have the art of medicine, so that is the one thing. And, where AI plays a role in many things, it's very good at things that are repetitive.
Right.
If you're accounting, something like that, yeah, numbers don't change. That's the way it goes. This is the way you balance your books. Okay, that's going to work that way. The laws, has interpretations, but, you can apply the law this way. But especially in surgery, I mean, I've always mentioned that, like fields of pathology where there's a lot of repetition, radiology, a lot of repetition of looking at what's normal and what's not normal. And if it falls outside of normal, that's where, it can be helpful, because it's good at, AI is a, very high powered spell checker, in a sense of that. So it does that. But I think in surgery, it can be helpful. And one thing, I was listening to a podcast recently about AI, and it says the best way to be involved in AI is be the expert in your field. So spend time learning about AI. Don't be afraid of it. Don't hide from it. Don't put your head in the sand about it.
Couldn't agree more.
Be involved in it. So when it comes to you, you're already riding that wave. You understand it. You're not trying to play catch up. So I think that's
that's great advice.
Yeah, you can future proof yourself that way, because
and patient selection, right? It's like 2 65-year-old patients with a 2-centimeter cuff tear and retraction of the mid-humeral head. One patient's doing great and they don't have any problems, and the other is severe pain and can hardly lift their arm. And it's that art of medicine, knowing who and when to offer surgery to these patients.
I'm sure you do it. I do it. You see the 2 meniscus tears in your clinic, and both are 2 months out. One guy's, feeling good, minimal swelling, no mechanical symptoms, but comes in with his MRI report and I need surgery. It's like, no, I think you're going to be all right. But that's, where you talk to them and explain and educate and spend time. Because if you weren't kind of ethical about it, you could say, yep, let's sign you up. Let's get that meniscus trimmed out. You'll be great. But knowing, okay, you're already great already, so you're good there. But then the other one who's got the catching and locking, got this ice pick pain stabbing through his knee every time he twists, you're like, yeah, you're going to do great. You need this. You're going to do fine. But just kind of knowing, yes, on imaging, on history, they're kind of presenting the same. But when you get into the nuance of talking to them, it's like, you need it, you don't.
Right, for sure.
And you've seen the 77-year-old guy who's got a massive cuff tear, who's got full motion and decent strength and no pain. Right. But he's just like, I just want to be stronger overhead. Like, yeah, can't do that.
Yeah. That's not in my power.
Like, well, you're just not going to be, So I always tell those patients, if you were, 4 months post-op and you had this range of motion and no pain, I'd pat myself on the back for doing a great job.
I use the same exact line. It's like, I cannot make you better than you are right now.
Yeah, you're already there. Yeah.
Yep.
So, well, just kind of one last sort of thing, a little bit of like, as you work with the fellows kind of entering their career as they kind of step in there, what's the 1 or 2 gold messages from Dr. Richter as going into the world that you try to impart upon them? I know you have, I've heard you talk, and you have many, great things to impart upon them, but sometimes you don't want to overload people with too much stuff. But what are the top 3 practice lessons that you teach as they enter the world?
Yeah, I appreciate you saying that, because that's something that I really enjoy and I'm passionate about. I would say, number 1 is you're never alone when you start practice, that no matter where you are, if it's a brand new setting or you've gone back to where you did your med school or residency at, you have mentors out there, you have friends. It is not a weakness to lean on people. Everyone has done it, and it makes you a better surgeon to talk to your colleagues and friends about any questions that come up. How do they manage things? And that's really important. So not just kind of burying your head in the sand and not talking to people. And when it comes to complications, because everyone has complications, if you don't have a complication, either you aren't honest with yourself or you aren't operating. So everyone has complications. They weigh on you. You'll lose sleep over it. There's no question about that. But talking to people about it. One of the first things I do is pick up the phone and talk to a couple of my partners about it, or see them in clinic and talk about it. Then if it's presented at like an M&M conference that we have, that even feels better. Honestly, it's just like a kind of weight off your chest that, hey, this happened. It sucks, but you face it. So I think that'd bring me to number 2 is so number 1 is, lean on people. But number two is when problems come up and complications come up, face that, like identify it, don't stick your head in the sand, and manage it. Because early on in practice, you'll be like, oh, this wound's draining. Maybe we'll throw some oral antibiotics at it and practice wishful, hopeful medicine. But it feels so much better if you're like, you know what, we need to take this back to the operating room, clean this out, maybe wash it out twice and just plan to do that. I had one of those recently where I cleaned something out. I'm like, you know what, I'm just going to put them on again for 48 hours from now. And I'm glad I did. There were a couple little vessels I saw that were oozing, and he had developed a hematoma and stuff. So that part's important.
I think I'll jump on those first two. But yeah, I mean, when you come out there, like you're so used to the academic setting, the training setting where, yeah, there's some guy right over here over your shoulder that's in it. When you first get out there, you feel a little alone, or you feel like you should know everything. You shouldn't ask anybody. Yeah. And that's like not even true at all. I mean,
yeah, you remember what I called that the other day? The empty wall sign. So yes. Yeah, one of my buddies who's a few years older than me, he's like, you have to know when good is good enough, because you're in there, you do a surgery and you want to look over your shoulder and have a thumbs up or a great job or pat on the back. There's no one there. So that's the empty wall sign. You have to know when good is good enough.
But there is someone there. So, and like I said, don't be afraid. You have practice partners, you have fellow residents or fellows that you worked with, you have that mentor from fellowship. I used to, text Ben Ma, Mark Safran. I use those guys a lot early on. Sometimes it's confirmatory too. You're like, yeah, oh, okay, I'm thinking right.
That's it. 98% of the time, probably, is it's confirmatory. But it feels good to have that.
You think you're asking a dumb question, or you should know this, and you do know it. You're just letting yourself know you are doing the right thing, because at the bottom of it, your drive is to do the best for your patients, and having that confirmation is the best for them. But don't feel bad, or like, because everybody wants to know, everybody wants to ask your fellow, and you're all in the same boat. As you realize, you talk to people like, oh yeah, I thought that too. I saw that guy too. Whatever it is that's out there. And the complication side of it is so true. You have to be upfront, and the more you kind of, divulge and, confess, in the sense of, with your patients, you went in there, like, whether it's a screw you had to replace or whatever it happens to be, when you go talk to them, they're like, oh yeah, like most people are like understanding, like, yeah, surgery is hard. They get it. It's like, and they understand these things. And if you kind of come out and talk to it, and we're going to do this, and it shows like you're engaged, you're involved, you're not, like I said, shunning it away and like, whatever, and I helped another young surgeon recently, was doing a reverse and had some problems interoperatively, and hey, can you go over and help him? And yeah, he go over and help the guy out, and he's like embarrassed. I'm like, dude, I had to crack 2 calcars in 1 week on doing shoulders. So like, right. I haven't done that in like 4 years, but I had 2 in a week. It's like, it's going to happen. You just gotta, all right, it's okay. And exactly what you said, if you're not having complications, either you're not operating that or you're not being honest. And my partner that I work with is like, if you don't have complications, you don't know how to get out of them, so it's
very true.
It's that's the best way to make you think, because when it goes perfect, it's easy. When you struggle a little bit, it makes you think harder. And sometimes you come up with a better way to do it next time, so you don't end up in that spot.
Yeah. And I found like that helps me with teaching residents and fellows. I'll be like, here, be careful with this part. This is why. I've seen this happen. I've seen that happen. I've seen that happen. That was our conversation today during this acute massive cuff tear. Was like, here, when you're doing this, don't shave too much there. That's going to bleed. If you do this part and you push it down too much here, you can worry about an anchor pulling out, or you could tear the suture here. Your knot may not be all the way down. I mean, all these different little pearls that you kind of find along the way, and then you learn how to stay out of trouble.
All right, so what's number 3?
Probably 2 things. I mean, number 1 would be, of course, or I guess number 3 would be never stop learning. It was interesting when I talk to folks that are even fairly recent out of fellowship, and they go to sometimes a more established practice, and some of the older techniques that are still being used, that a lot of them had gone kind of by the wayside, but those surgeons just hadn't kept up with the literature, didn't go to meetings or conferences or, read primary literature. So I'd say, stay up on that, make it a point to just understand what's coming down the line and don't have to be the first to adopt it, but you shouldn't be the last either if it's something worthwhile.
Yeah.
And I think number 4 is what you and I talk about a lot, is when you go into practice and when you're choosing a practice, don't worry what that number is, that bottom line with how much you're going to be getting paid. I know everyone wants to have a good paycheck off the bat, but there are a lot of other tangibles and intangibles, and you'll develop, you'll grow, you'll build your brand, and there's a lot more to it than just what that first year salary is.
Oh gosh, I mean, I hammer that home every time we talk to these people because, I mean, it's an ego thing. There's no doubt about it. I mean, you spend, you go through the 27th grade and you need your due. You made it that far. You feel like you've earned it, and so you do want to kind of see those numbers on the paper. But exactly what you said, you'll learn later on that we make a great living, we do well, we're going to be able to take care of our families and do things like that. And it's more important that focusing on good outcomes, taking care of people the right way, and everything just kind of falls into place after that.
Yeah. Couldn't agree more. Do the right thing.
Yeah. Yeah. And so jumping back to like your staying current, it's funny, Dr. Renshaw, he was one of our pediatric spine guys who was residency director and just a super good dude. But, he was always stay 2 trends behind, so kind of that's like you said, don't be the first to do it, but don't be the last, but kind of somewhere in that realm, like kind of watch and see how it settles out and like, okay, I think it's working now. I'll learn that because there are people out there in our specialty that are the pioneers forging the way forward. It's kind of like venture capital. Not all of those are going to hit. So
right, exactly.
It's like, well, I don't want to take up too much of your time. Man, it's been always great catching up with you. I mean, it's such a thrill to work with you. I learned everything every time I work together, and I look forward to it again. And I really thank you for being available to be our guest here. And I think you gave a lot of great advice to the young surgeons out there, and we truly appreciate it. And we both have a huge passion for mentorship, and I think it's great.
Yeah, we do. I mean, that time just flew by. So, Hunter, thanks a lot. I really appreciate it. You and everything you're doing.
Thank you, my friend. All right. We'll see you soon.
All right, man. Take care.
Healthcare Unscripted is powered by Fairwinds Medical, the commercialization team behind some of the most innovative technologies entering operating rooms today. With national reach and clinical expertise, Fairwinds moves new solutions from promising to practice. Visit fairwindsmedical.com to learn more.